शेअर लिंक पाठवते सरांनी म्हैसूर हे कसं ग्रुपलाच पाठव. राकेश राकेश होय कुठं हे रोटेट डिवाइस म्हणतो बघा. हो नंबर सांग 820-877-3459. दिसते का व्यवस्थित बघितलं का सरांचे ते लिंक हे करून बघ ना. काम करते ती लिंक आहे ना तुला मला पाठवू.
We'll start the session in next 2 minutes. I request Bhalerao sir to come inside. Our president and the dignitaries who are taking tea to be please come inside and be seated on the chairs. Should we start? And all seated on the chairs. Thank you so much and a warm welcome to everybody for participating on a Sunday morning. Sundays usually are for families and some entertainment for all of us, but it's really very good that all of you have come here for a brainstorming academic session. And as doctors are very much known for their academic interest, they नेहमीच अभ्यास करत असतात आणि संडेलाही ते अभ्यास करायला आले. त्याच्यासाठी let's give a big round of applause to ourselves because we have come here to study something, to know something that we actually know from age long. आपण नेहमीच या गोष्टीचा व्हॉट्सअपद्वारे किंवा आता आजकाल व्हॉट्सअप बोलायलाच लागतं प्रत्येक ठिकाणी. बट वी हॅव रेड मेनी बुक्स, वी हॅव heard many speakers, we have gone through many journals, we have gone through many situations, life situations in our practice of say 20-25 years, some are 30 years, some are 40 years of practice. They have gone through many incidences in life, they have taught us. But in spite of learning so many things all our life long, every patient who sits into our chair teaches us a new thing. That is also an important thing for us. Still on a Sunday morning, we are here to learn something new, and again to somebody who are very senior persons here, they are again going to revise what they have learned all day. Many of them know the sections, many of them know all the legalities, but still they are sitting on the chairs, and they are all big dignitaries and very senior persons. And I'm really highly, morning session I start with that Thanksgiving session only for that the chairs are being occupied by very senior persons here. Thank you so much, sir. This valuable Sunday is going to be with a specific purpose today. We will talk about purpose. When we talk about purpose, we have to accept that everyone in our practice has started his medical practice with a certain purpose. The purpose is to learn the livelihood. The purpose is to serve the society, to serve their patients for their better health, and to abide to the rules and regulations of the law of land actually. So we have to follow those rules of land, rules and regulations which have been created by the authorities, by the judiciary, by the parliamentary section, and then we have to practice our profession. That's a big task for all of us. Doctors at heart are really genuine, kind. They never want the patient to be in a problematic situation, in any given untoward situation, but to have help. There are situations nowadays going on. आपण खूप साऱ्या ऑल ओव्हर सोशल मीडियावरती बघतो की देर आर सो मेनी थिंग्स गोइंग ऑन ऑल ओव्हर इंडिया, ऑन अदर स्टेट्स, इन अदर डिस्ट्रिक्ट्स ऑफ महाराष्ट्र, इन अदर स्टेट्स ऑफ इंडिया, and there is a panic wave always being created everywhere. Something has happened to some XYZ doctor in some XYZ state, and the whole fraternity all over India has a very concerned mind, and then keep on discussing things, what we should keep doing or not. But doctors at heart are never wrong in treating their patients. Their intentions are never wrong that the patient has to have the complications. These purposes in life really make us very special, because no other profession in the world has such kind heart, kind mind when we are treating our patients. Doctors are really very expert in all their clinical values. We have learned lots of books, we have studied so many years of our life, 5 years of post-graduation, graduation, and then you have 4 to 5 years of graduation, post-graduation, and then people are coming here into the practice at a very later age. They are experts in their clinicians, but they are jack of all and they are master of all also. Because when you sit into an hospital, corporate hospitals might have bigger settings. We are sitting here like in a Krishna Diagnostic. We have a corporate hospital building. People are there to help, and even these people have helped us for so many technical things. But when it comes to 50, 25, 75 bedded hospital, a group of few doctors, or say 1 or 2 doctors are starting running the hospitals, and really very difficult for them to multitask. And the multitasking efforts we have to learn ourselves. This multitasking is the most important aspect of our life. Though we boost ourselves as very good clinicians and we are very good in our diagnosis and treating the patient, multitasking is the only aspect which is going to make us survive in the society, as we are already entered, rather I am using the word going to, I'll say we have already entered the era of consumerism, where we are going to be handled, we are being taken care as a consumer service provider, and we have to have that multitasking. And this multitasking only comes when we are having these continuous medical educations, we are upgrading ourselves, we are sitting in all chairs of administration, say reception counters, a desk counter, we have to know the nursing counter, we have to know what our mama maushis do, we have to know everything that is being going on in our hospital if we are running a smaller or a bigger hospital. So this multitasking is really very, very important. So welcome all for this academic feast. without taking much of a words, I just wanted to give little guidelines of what we are going to learn. We are not going to be a godlike figure henceforth. Rather, we are not going to be, we are not right now only at this particular day on Sunday, we are not a godlike figure for patients. We are vulnerable to human errors while we are doing multitasking. When we itself have a human error, our staff has human errors, our reception counter, our desk has human errors, and we are liable and responsible for all the human errors which our staff, ourselves while conducting our professional conduct happen. Society norms and the way situation is being handled are non-changeable. We cannot change the society in one night. In the last program, I have said that one particular step which we take, we have taken that particular step of thinking that we are going to learn ourselves, we are going to upgrade ourselves, and then only we are going to. This one particular step has made the change in the medical fraternity. There are lots and lots of CABs and lots of people who are going to come into the medical legal aspects. I really appreciate, even in PCMC, there were one or two people, sir, very senior persons from Pune. When I have learned my LLB or I have learned by my practice, I practiced in Pune for say 10 years when I was after my internship and all. I could see very few names like Naurangi sir or Gupte sir coming forward and making the society aware of the clinical hinges and the medical legal issues. We have learned from them. We have seen them as figures of iconic figures. Then actually we're taking inspiration. There's so many people who are coming forward, trying to communicate each other. And this way we can see all over Maharashtra, even if you go to Thane, you go to Vasai, you go to Bombay, there's so many people, so many communities are coming together under one association. And after every 1 to 2 months, we are seeing medical legal CABs being conducted. That's the very best part. Cultural activities, sports activities, I agree to you, they're very, very important. They have to be important for the recreation, for the brain, for their well-being, the mental well-being of the doctor. But educational programs are to be conducted, and medical legal being taking the prime stage nowadays, it's very, very appreciable for all. Thank you so much, sir. There are really very iconic people like Kamath sir and all in PCMC. The last name comes in PCMC will be Kamath sir. The first name will come into things will be Naurangi sir. There's so many people, Lalit Kapoor sir is going to be there with us in no time. He is the founder of AMC. AMC is being the pioneers in having medical legal issues. So these are all very senior speakers. I would urge from here since morning only that have a sincere approach. Even I have learned in my LLB all these sections. But when I listen to Bhalerao sir, I will be noting down all the sections, he will be revising me. Everybody will be revising, that such things can happen. Each and every small child also teaches us something. Here, everybody is going to teach everybody something. So when it comes to the sessions, after the sessions, I would please expect that there has to be proactively question answers from the audience. Feel free to talk at any level. These are dignitaries who have learned themselves. Bhalerao sir, I would like to say that sir is a very, very senior person. When he comes, now it is IPC, I have to talk about IPC. He said, I will learn about IPC, I will make my own PPTs, I will see to it that I will read it. Then the effort has to come from the other side also. Try to learn those sections. You cannot run away from these. You have to face that tomorrow. 304A has to be there. You have to know what is 304A and 304. You just cannot say ki मी वाचेल, मी काहीतरी करेल, मला जेव्हा होईल तेव्हा मला काहीतरी करेल. We have a very bad habit की माझ्या खुर्चीच्या खाली आग लागल्याशिवाय मी पळणार नाही. Do not do that. Have yourself learn it, आपण स्वयंपाक करतो तेव्हाही आपल्याला घरात मोहरी कुठे जिरा कुठे तेल कुठे माहिती पाहिजे तिच्या स्वयंपाक करता येत. Similarly, these sections are. You have to know these sections unless and until you don't practice, because clinically things are going very different and professionally things are really going very different. That will be elaborated very nicely with all the speakers. So thank you all, initially all the speakers who will be joining. Consumer Forum will be joining. I just wanted to tell you one more thing about that. There are very senior Consumer Forum people all over Maharashtra. They will be speaking, they will be giving academics. I have tried to include our Pune District Consumer Forum. One-to-one ओळख होते, आपल्याला लोकांची interactions करतात. You have to know that who is there in PCMC for the medical negligence cases, who will be there in Pune. And if we have one-to-one discussion with these ground level people, last program we had Professor, we had somebody who has come, because they are actually the authorities sitting into the program, and we have to face one-to-one with them. So tomorrow, we're not senior speakers here, but in the consumer forum also we try to get the actual right now presently sitting presidents and presently sitting members who are handling this. So they will have their own view. They are not doctors, they are advocates, or they are legalized person. They will have their own view, their way of thinking. ते नेहमी डॉक्टरांनाच नाही ऐकायचं, त्या ज्युडिशरी साईडमधूनही कितीही लेवल असली तरी आज आपल्याला पुण्यात त्यांना फेस करायचं आहे, तर आपल्याला त्यांनाही ऐकायचं. So this way we are going to conduct this complete program. I would hope each and everyone to have their phones on silent. चुकून माझा फोन वाजला तर प्लीज हे करा, कारण there are many people who have my number and speakers are going to communicate. But still, if you all can silent your phones and little about PHAPD. Now, as the slide shows, it's a big name, PHAPD, and as Surendra Patil sir calls it as PHAPD. I don't know what he calls it as PHAPD, but it's PHAPD, and it is Private Hospitals Association. I have spoken a lot about when we had an inaugural program, and there is a website and there is everything about. But this honor will be done by Dr. Bhalirao sir when he comes on the dais. Before he speaks about his topic, all the information about Private Hospital Association will be given by Bhalirao sir. And sir will speak out all the necessary requirements of how to get aggregated under one roof so that we solve the issues of hospitals. Sir, just few words. I extended little 2-3 more sentences. I'd like to call you on stage. You please conduct the first session about our hospital association, and then you can carry forward with your lecture later. We'll have the inaugural program in between the session. Thank you, sir.
Thank you, Anjali madam. Respected dignitaries, respected senior colleagues, my dear friends, the office bearers of Private Hospital Association Pune District, a very good morning and welcome to all. Basically, the journey of Private Hospital Association Pune District started almost, I would say, the initiation was 2 years back. You know, on the WhatsApp group, we had started a discussion because there was, you can see the last line, let's raise our concerns. There were so many concerns among the hospital owners regarding the registration, regarding so many things, hospital violence, you know, attacks on the doctors. So we need to have some good, strong association as such. We do have associations in PCMC, but if we see for an hospital association as such, there were none. So we had Dr. Boyd and few other colleagues, basically, we started thinking about it. Okay, let's come together. And slowly, we had come together, and this was the day on 10th of March, we could register, and we could form our Private Hospital Association Pune District. So if you see here, this was the inauguration program, which was done by the past PCMC Police Commissioner Shri Krishna Prakash ji, which was on the 10th of March at Aditya Birla Memorial Hospital, Chinchwad. We had the inauguration of our association, there was unveiling of our logo, and also there was a launch of our Private Hospital Association Pune District website. So all three at a time we had done it. These are our office bearers. The President, Dr. Ganesh Boyd, Secretary, Dr. Pramod Kubre, Treasurer, Dr. Madhur Sawan, and the list of trustees here you can see. So basically, what is our vision and our mission? Is united to provide ease of professional practice and serve humankind. The last two words, the serve humankind, is somewhat disturbing nowadays. There has been a sore relationship between the patient and the doctors to it. But then we need to solve this problem. We need to create a big and a strong bond between the patient, and we need to continue this word as serve humankind. This is right from where we take the Hippocratic oath. So the Private Hospital Association Pune District is a non-profit organization that works tirelessly to protect the rights of private hospitals and to uphold the honor and dignity of every small and large hospital that provides healthcare services to humanity. These are the few member benefits to it. Any hospital registered under Bombay Nursing Home Act is eligible to join as a member of the association. And you can visit the website, you can get all the details into it, and I would urge that each and every person, every hospital owner should join it. This is our strength. We had the inauguration on 10th of March, and in 2 months, we have 110 hospitals registered till today. There are almost 80 hospitals which are up to 25 bed, up to 25 hospitals which are 50 bedded, and up to 5 hospitals which are up to 100 bed, and many more to come. So my sincere request to all to join the only private hospital association in Pune district to fight for your right and for your dignity. Thank you very much.
Call the chairperson.
Please.
I would like to call the chairpersons of the session of the first meet. Sir is going to conduct the first lecture on IPC Indian Penal Code. Our doctors really aware about it. I would like to call Satyajit Patil sir to please come ahead and be seated on the chair. And Satav sir. Satav sir is not there. So please be said that these two are our chairpersons for today's session. Sir, few token of appreciation, and that is very mandatory for every official function. So I first like to felicitate you as our patron and the first speaker, and then we'll connect with the lectures. I just want to have a few introductions for those who are really unaware. Very few people are unaware about Sudhir Bhalera sir, but still I have to give them an introduction. Sir is an MBBS ENT surgeon, ENT consultant, and he is MCPS and URL. Just a minute, I take the slide about. Sir is practicing as an ENT consultant in PCMC. Bhalera ENT Hospital in PCMC provides services to the latest technology of endoscopy and laser and coablation. Actually, I don't know what's coablation, but I'll still come to you and later I know what coablation means. Sir is president of Association of Otolaryngologists of India, a Pune branch. And for PHAPD, there is the most reliable and the honored patron of our association. She's always been on forefront to solve the issues, and whatever problems we find during the functioning of the association, sir is patroning us very proactively. He will come forward and talk to us and ask us what you are helping in, and really very, and thank you sir for being there. So I call you upon dais. First for the felicitation, I call Dr. Pramod Kugde sir to felicitate Dr. Bhalera sir. Thank you, sir, for your valuable. Because question answer sessions will start, so I will felicitate you first.
Thank you.
I would like to felicitate Dr. Satyajit Patil, sir. I will call Sarika Goyal madam to please do the honors. Sir, thank you for chairing the session. continue. We'll have illustration with Sarthak sir also. Thank you, sir, for assuring the chair session. You will be contributing to the question answer session also later on when the session comes. Sir, please take on the dais and continue with your session.
Thank you, Dr. Anjali ma'am. Basically, Dr. Anjali ma'am has got a big support in forming this Private Hospital Association Pune district. She is a strong pillar here, and I would like all of us to give a big applause to her, because this medical legal CME is all, she has done these efforts, she has taken a lot of efforts to it. We have just contributed, but she has taken a lot of efforts for it. Thank you ma'am, thank you. So friends, basically Indian Penal Code, are doctors really aware? You can see this cartoon here. You know, what does it say? The justice, it's a tortoise. So you can judge what exactly the tortoise, it's slow. Okay, and definitely the other person, please, he's not Amit Shah. Okay, he looks like that, but he's not Amit Shah. But it's a person, you know, from the government, he's reading the IPC to it. So what is the need basically? Is there really, does the doctor really need to know all these IPCs? So basically, we are going to deal today the criminal law and health professional related IPCs only. So what is the IPC? It's an official criminal code of India. It defines the offences and the quantum of punishment under different sections to it. Believe me, it extends for whole of India except Jammu and Kashmir, because they enjoy a special status and they have their own Ranbir penal code. So only Jammu and Kashmir is having a different penal code, but rest of all of India, okay, it is an IPC. It is IPC. But who are immune regarding this IPC? The President of India, the governors of all the states, diplomats, foreign diplomats, they are all immune from these IPCs. If I mean immune, means they cannot be charged under any sections of IPC. They cannot be charged. So is there a need for us to know about it? Yes, of course there is a need. Because why? The quantum of offences and the punishment thereafter is decided by IPCs. Okay? It's a criminal law and the health professionals. So there is a rise in the consumer awareness among the patients. So we should know about the IPCs. Definitely, we have seen the latest one which has happened in Rajasthan. There was a wrong implication of the section of IPC, and we know what has happened. Everybody knows what has happened to it. So before, if anything goes wrong, if a police charges or writes a offence against us, we have the right to know what is the IPC, under which section does the police have charged us, and definitely we can discuss with our lawyer and we can go ahead with it. So wrong implication of the section of IPC due to unknown resources. You know what is the meaning of unknown resources? There are a lot of pressure in the society, political pressure, relative pressure, so many things. So before we go ahead with the IPCs, there are 4 things which we should know, which is very important. That is fundamental elements of crime. 1, human being. To charge somebody under an IPC, he should be a human being. He should be a human being. Second is the mens rea. Now what is meaning of mens rea? Mens rea means there should be an evil mind, there should be an evil intention. For an example, a gynecologist doing an hysterectomy and the patient dies, okay, on table. But the doctor doesn't have a criminal, an evil intention of that. He is doing a surgery, okay, but death has occurred, that is definitely. That needs to be proved, negligence is, but he doesn't have a evil intention. So the mens rea part of it is very important in case of our doctors thing. Then actors be as illegal act or omissions. So negligence and all these factors, they come into it. And the fourth most important thing is an injury to another human being. That has to be proved. Means the person has been harmed, has been injured, whether any major injury, minor injury to it, damage to the properties, everything they come under this category. So these four fundamental elements of crime has to be there, and we should know exactly to it. So what are the relevant sections of the IPC? As I told you, the criminal law and health professionals, we are going to deal only with that. So according to the provisions of the IPC 1860, any act of commission or omission is not a crime unless it is accompanied by a guilt mind. You understand? Or an evil mind or an evil intention. That is mens rea, what I just told you. The acts are not punishable only because it led to some mischievous results unless associated with intention or mental attitude of the person. So to commit or to prove a crime, the court has to prove that there has to be an evil intention. There has to be an evil intention. Most of the times, doctor's treatment is in good faith. So there is a section also in good faith also. There is a good faith section to it. So most of the doctors, they come. See, we are saving life of a patient in good faith. Okay, but sometimes we are unsuccessful. So that doesn't mean that we are negligent. That doesn't mean that we have created a crime. Okay, so most of the time, doctor's treatment is in good faith with the consent of the patient, and hence most of the provisions of IPCs are not applicable to the doctors unless or until there is a rashness or a gross negligence. Okay, somebody has done a laparotomy and he has forgotten a mosquito forceps inside. That's a negligence. That's a negligence. Okay, so that is not part of it. That is not part of it. So let's come and deal with the different types of sections. We are going only which is related to it in short because there are so many sections to it. So section 29 here, the first and the foremost thing is deals with the document. What is a document? It's very important factor when some mishap happens. It's very important because the word document denotes any matter expressed or described upon any substance by means of letters, figures or marks, or by more than one of those means intended to be used or which may be used as evidence of that matter. So one thing we should remember that documentation is very important. I think Dr. Naurange sir is going to speak on that, we will be elaborating it. The section 52 describes the good faith. As I told you, nothing is said to be done or believed in good faith which is done or believed without due care and attention. Section 19 is related to the consent. Consent known to be given under fear or misconception. Now these are again different sections which are also important to us. One is section 176, failure to inform police whenever essential. So many times accident cases comes to our hospital, we don't inform. Now if we don't inform the police, the patient dies. The patient dies if the patient relative sues us or file a criminal case. Section 176 also can be implemented on the doctor that you have failed to inform the police during this. Section 269 to 271, they are related to spread of infectious disease and disobedience of a quarantine rule. Now this has come in limelight during the COVID rules and all these things. Okay, this is just for the information basically. Like 270 is a malignant act likely to spread infection of disease dangerous to life. Disobedience to quarantine rule. And 272 to 273 is related to the adulteration of food and drinks. Section 276 is the sale of drug as a different drug of preparation. we doctors don't have a right for sale of drug. We don't have a right. We cannot combine two drugs, mix it and give it to the patient. We cannot do that because we need to have a license for that. We need to have a proper registration for that to it. And if some mishap happens under section 276, you are liable for it. Section 304A, very important. This is something which has come in limelight after the Rajasthan incidents to it. It deals with the death caused by a negligent act. Whenever there is a mishap, like I told you right from the start, a hysterectomy, patient died on table, okay. There is no evil intention. There is no evil intention to it. It's a good faith. So 304A is the right section to be applied during this time. Section 306 to 309, all they are related with abatement of suicide. 307 is attempt to murder. The lady in Rajasthan was charged with 307, that is the attempt to murder. 308 is attempt to commit culpable homicide. We are going to discuss in little bit in elaborate in the next slides. 309 is attempt to commit suicide. Section 312 to 314. Again, this is important for the gynecologist people. They are related to the causing miscarriage, abortion, and hiding such facts. I think there was certain incidents in Sangli, I think, where the doctors were they were acquitted for that, and section 312 were causing miscarriages. 312, 313 is causing miscarriage without woman's consent, and 314 is death caused by act done with intent to cause miscarriage. 315 to 316, they deal with the act to prevent child being born alive or to cause it to die after birth. So section 315 and 316 in detail they have given to it, that act done with intent to prevent child being born alive or to cause it to die after birth, and 316 is causing death of quick unborn child by act amounting to culpable homicide. These sections are also important here in a reverse way. Like there is a mob attack, the doctor is attacked. So we should know exactly on what sections, okay, what IPC should be charged and let the police put, for the patient relatives who has attacked the doctors to it. So section 319 to 322 is related to causing hurt, grievous hurt, loss of vision, loss of hearing, or disfigurements to it. 319 is just related to hurt. Somebody is hurt. Okay. But 320 is grievous injuries or grievous hurt to it. 321 is voluntary causing hurt, and 322 is voluntary causing grievous injuries or hurt. 336 to 338 is deals with causing hurt by rash or negligent act. It's an act injuring life or personal safety of others. Now 336, basically a doctor who's performing a surgery but has been proved that he has intoxicated, he has taken alcohol. Okay, so he is endangering life of that patient. 337 is causing hurt by act, endangering life or personal safety of others, and 338 is causing grievous injuries or hurt by act, endangering life or personal safety of others. 340 to 342 are all wrongful confinement, breach of contract, and these are related to defamation part of it. Now let's go into detail about section 304 and 304A. See, there has been a lot of discrepancy while applying these sections in cases of professional negligence by doctors. most of the time the police authorities register the cases of professional negligence death under section 304 of IPC. But we should not let them do this. We should not let them do this. According to this section, the offense is non-bailable. First thing, 304 is non-bailable. In fact, the police should register the cases of death due to medical negligence under section 304A of IPC. A 304 of IPC, in which the offense is bailable and the doctor can be released on bail. The basic difference in that is that section 304, there is an intentional act of negligence, while in 304A, the act is never done with the intention to cause death. Okay, so that is the intention, the evil mind to it. Okay, so this is very important. This is very important. This is the safety of our doctors. The Indian Penal Code, where 1 to 6 you can see misbehavior, the duty, use of abusive language, 3 to the duty doctors, attack on this board. Every hospital should have this board. And actually, I would suggest, Dr. Mohit sir, our president, our association should print this and to give each and every members that they should have this and put it in each and every hospital. So you can see, for misbehaving, almost 2 years imprisonment under section 504 is there. Use of abusive language. If you record any patient or patient relative giving abusive languages, using abusive languages against doctors, you can record it, and 504, 2 years imprisonment is there. Even a 3 to the duty doctor, 506, 3 to 7 years. Attack on duty doctor, again 3 to 10 years. Damage to the property and equipment, 4 to 7 sections is there. And forceful entry into the hospital. Nobody can enter the hospital at his will. If a doctor refuses, the doctor has all the right to refuse the treatment, okay, of a patient, only not in emergency cases. Okay, if it's a cold case, if it's a routine OPD case, he has the right to refuse. He can very well say, "Maji tabiat aaj bari nahi hai. Mala bara watat nahi." So that is a valid point. Okay. All imprisonment is for 2 years and they are non-bailable. They are non-bailable. And this is all over India. This is all over India under the Indian Penal Code. There are few common terminologies you should know, basically. Sometimes there is a summon, there is a warrant, there is a cognizable offences. आपण ऐकले ते शब्द, पण आपल्याला खरं त्याचे अर्थ आपल्याला कळत नाही की नक्की काय आहे. त्यातले खरं त्यातला तो अर्थ काय आहे, म्हणजे काय आहे ते. The summons is the process of court asking the opposite party to appear and answer the allegations preferred by the party who has brought action. It's a summon from the court. You have to attend. You have to go there, and you have to do that, because if you don't attend the summon, then the warrant comes. Warrant means an order issued by the court, magistrate, or a competent judicial authority directing a police officer to make arrest, seize, or search, or to do any other work incidental to the administration of justice. What is a cognizable offences? These are those in which a police officer may arrest without warrant. Okay, the police officer comes and says, "You have committed a cognizable offence. I have come to arrest you." Okay, the crime should come under the cognizable offence. Then only he can come without a warrant. All cognizable offences are those in which a police officer can't arrest without a warrant. Illegal offences are those in which bail can be granted by any law or liability. So, very important basically. It's very important basically here that whichever section has been put on us, okay, 304A, that has to be a bailable one. Non-bailable one, you are in a suit. So non-bailable offences are offences other than the bailable offences, or an offence in which a bail can't be granted to it. So when do we inform police? A doctor has to inform the police in the following circumstances. 1. Cases of suspected homicide, cases of suicidal deaths, unknown unconscious patient, death on operation table, suspected unnatural death, sudden, unexpected, violent and unexplained death, instant death after treatment or reaction of medicines, married lady dying within 7 years of marriage due to any reason. So information to police shall preferably be in writing, and the written acknowledgement should be obtained. If the information is on telephone, it's a telephonic, then one must note down the name of the police officer, the buckle number, designation, and the address of the location of the police station. So can a doctor be arrested? Of course he can be. Doctors have no immunity against arrest. He can be arrested, but he can get a bail also. So always, whenever you have a police, you have to have a lawyer besides you, and you can have a bail. If a FIR is lodged by a patient or a relative, then the police may arrest the doctors. Hence, if you think that there is going to be a cure, the relatives are going to repatriate, the relatives are going to be against you, then it's a better approach in cases where we feel that the patients or relatives may create nuisance. Will be the doctor should lodge an FIR. That is the first information report that a particular incident has happened in my hospital. These are few do's and don'ts. Inform police whenever necessary. Extend all possible cooperation to the police. Furnish copies of medical records to the police, court or relatives whenever demanded. Consent of the patient may be taken while providing information to the police. Follow the legal procedures. Have a valid informed consent for the treatment. Preserve the documents, records, especially in medico-legal or complicated cases. Insist for a PM examination if the cause of death can't be ascertained. Involve medical associations or our association, medical legal cells, voluntary organizations. Consult your lawyer before giving any reply or statement. Don't become panicky. Don't manipulate or tamper with the documents. Don't do unlawful or unethical acts. Don't issue any false or bogus certificates. Don't neglect the treatment while completing legal formalities, especially in serious or emergency situations to it. So here are a few things which you should remember, which can land up you in problems. You can see it's very elaborative. I'm sorry the slide is not very clear, but it's a failure to X-ray the fractures, missing the fractures, removal of wrong organ, wrong digit, transfusion mistakes, anesthetic mishaps, tight plasters, wrong side, wrong patient, paralysis from the spine, retained objects in the abdomen or in the body cavity, surgical errors like ligation, cutting the ureters. So all these things, these are medical negligence. Okay, this needs to be tackled. This needs to be handled very carefully, and we can come out of it. Thank you so much. Thank you for your patience. This is me and my wife Maya at Antarctica. That's the South Pole. Thank you. Any questions, please? The forum is open for questions. It's very theoretical, basically. You all should know these things. We can think of printing these IPCs, and every hospital should have a file of all these IPCs and keep it as a record to it. It's very hard to remember all these things, but you can refer. You can definitely refer to it. Yes, sir.
Dr. Sudhir, I would like to add 2 things.
Yes, sir. Please.
IPCs are there.
Sir.
Everybody should know it.
Yeah.
Can I?
Yes.
Yes, sir.
IPCs should be known by the doctors. There are certain things which are happening right now. Few of the cases which I came across last 4 or 5 years before COVID and all this thing. A patient was got to the police station, the police have not taken the complaint. The patient has gone to the court and court has issued an order to police station under 204. 204 and 204A makes a difference.
Yes, sir.
204A is only inquiry, but 204 means you arrest the doctor and then inquire, where there is no question arises. Now this thing has happened with successfully 2 cases in this area, 2 hospitals. Fortunately with good officers with DCP, because even police inspectors they don't have a power to arrest you. There has been a permission from DCP. Since I came to know, we have approached the DCP and the arrest was prevented. But this is the thing which is happening right now. And court has successfully given 2 or 3 orders in this infringement study. So mind well that this is the thing which is happening in this area. Second thing, this Ranveer code has gone from.
Yes, sir. Yes.
The third important thing is that right from the beginning, when we have formed the PCDA, I'm insisting that you should have a lawyer whenever the.
Absolutely. Absolutely.
To give a statement in the police station. The famous Subida case, I could bring out my all 4 doctors just because I was having a lawyer.
Lawyer.
He was just fortunately with me from High Court.
Absolutely.
He went inside and he found out that the inner courts, they are available, so we have given them, all 4 doctors came out within 1 hour.
Yes.
So that is the thing which I am insisting for everybody. Unfortunately, over above, 2 other doctors who went to the 2 doctors who have gone to the police station and got arrested. Because they were not having a police.
Lawyer.
So this is the thing we should avoid.
This is a take-home message, basically, what Dr. Kamal sir has told. Okay, these are pearls of wisdom. Sir, good morning.
Good morning. Good morning.
Good morning. These are pearls of wisdom. It's basically never go alone to the police station. Never. Always take your lawyer. See, just think, all this corporate world, these companies, every company has got their department, the lawyer department. Why they have it? They have to have it. Why doctors don't have it? Now I think it should be a part of it. Every hospital should tie up with 1 lawyer. In foreign countries, it is a compulsion. They have to do it. They have to. And when there are few complicated cases where the doctor feels that the patient may die in the operation theatre, when they take the consent, the lawyer is also present in the room at that time. So that has to be there. So I think the lawyer has to be there. Now it's a time where we should need a lawyer with us. Okay, we can. I'm very frank. We can start charging a little more as a legal charges in the bill for the patient. Okay, but we should have a lawyer. We should have a lawyer. Yeah. Yes. Sir. Yeah. Good morning, sir.
While performing surgery, we usually take consent for vascular injuries.
Sorry, sir. Yeah.
We take consent for vascular injuries, not for nerve injuries. So, what should be written in that?
No, sir. Basically, the consent, okay, it depends upon each and individual specialty. Okay, like I'm an ENT surgeon. Okay, a simple tympanoplasty surgery. Okay, but still in my consent, it is written that you may lose your hearing. Okay, it's very clearly written because patient can land up with a infection, patient can land up with a viral infection, and he can get a sensorineural loss. The ear can be dead. I have seen few cases like that. I have seen. So you have to. It is not. If you are a vascular surgeon, you have to very specify in your consent form. Okay, you have to write each and every the vascular elements, the nerves also. What are the complications? What can happen? you have to elect that time.
Sir, I'd like to tell you one thing, sir. Procedure-specific consents are very important.
Yeah.
It cannot be doctor-specific consent.
Yeah.
It has to be procedure-specific consent with complications to be
Yes.
mentioned and actual what book says in the consent in written hand. And that will be elaborated by Navrange sir when in his
Yeah.
lectures. Consents and
Yeah.
there will be speaking more
Documentation
about
and consent,
that.
sir is going to.
This point when on the panel discussion at enlarge, sir. This is a very important topic which you have put forward. Thank you, sir, for making that possible. But we will actually take Navrange sir's lecture. He will elaborate us and then we'll take that in detail.
Sudhir, congratulations. Very nice presentation.
Thank you, Santosh.
Just a simple point, which we come across many of the times. Patients with domestic violence, the slap on the ear, and the drum is perforated.
Yes.
Now by now, this is a cognitive offense.
Yes.
Right? So if
It's a grievous injury.
Yes, if we say that this has to be informed to the police, patients do not agree. They do not agree, and in good faith, we give treatment, patients get better off, that's fine. But if afterwards, after some time, these patients go to police or go to court, then there can be problems. So I want an opinion from the audience and the panel. If patient refuses to inform it to police, what should be our stand?
Actually, Dr. Latkar, Dr. Madhav sir has initially every such cases has to be informed to the police.
It has to be informed to the police.
And I just want to add one more question.
Santosh, I'll tell you. Just few years back, I had a summon at Shivaji Nagar Court. Okay, same case. A person was driving. Okay, he hit one two-wheeler person. That two-wheeler person came out. Okay, he also came out from the car, and that two-wheeler person slapped. Okay, he had a perforated drum. He had a perforated drum. There was a case. He came to me for the treatment. I did his patching. Okay, his drum was absent. After 4 years, I got a summon. After 4 years, After 4 years, I got a summon. So I just 2 minutes I take. I went to the court. Okay, so the person's lawyer he came. Okay, the patient's lawyer he came. He asked me what happened. So I said there was an injury when this patient had come. So how do you know there was injury? I said there was a perforation and there was a blood clot around, and it was a fresh perforation. So what would have happened? Well, I have to take history. So patient said that such and such person slapped me. So I had written on the things, and I had done an MLC also. So okay, fine. So he told to the judge, you see, that has happened because of the slap. Now the other person's lawyer, he came. Okay. So he said that, okay, you feel that it's a fresh perforation? Yes. Okay. Let's go little reverse way. Okay. Before he slapped, okay, what happened in the car? He was in the car, he dashed. So there was an accident. So that ear must have hit the window of the car, and is that can cause perforation? You understood? So I said, yes, that can also cause perforation. So he said, then what is the proof? That because of my he has hit the person and he got a perforation. He must have got it before only, during the accident. So it's very difficult, lawyers play a lot of games here. Thank you very much.
I just want to one more question.
So we take a question.
Is there any format, if there is a death in the hospital, is there any specific format of informing to the police, or we have to submit more papers at that time?
Incidence report, sir. We will see an incidence report. Unless and until there is a complaint, there has to be no papers to be submitted to the police.
That's a very good presentation.
Information. But you need to take information. Whom you have informed. The police station, the buckle number, everything, time, date, everything has to be known. And they give a number also, MLC.
Thank you, sir. It was a nice presentation.
Thank you.
Thank you for such a nice presentation. Though actually it was very section specific. थोडंसं boring असतं, numbers नाही घुसत डोक्यामध्ये. But still you have to bear with this because we have to learn those sections. Thank you, Chairperson sirs, for if you really want to have a few words, you can. or we can have a discussion on the planning session. Thank you. Lalit Kapoor sir is already arrived here. So we'll thank you, so welcome here with the dais of PCMC. Sir has travelled all the way along from Mumbai and have come here. We'll do the official felicitation session first and we'll continue with the next lecture. Kindly, all of those dignitaries who are there, please come in front. We'll have a official light inauguration, lightning of the lamp. Sir Kamath sir, please come. Bansal sir, Devdar sir, please come. This is the first. Sir, या ना. Sir, या ना.
Come. You are the opening batsman.
He's already scored.
नायकाय गणदैवताय गणाध्यक्षाय गुणवन्दिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि गजन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि.
So please come. Sir, यावर इकडे ना sir.
I'd like to continue the session because we are lagging already late and we are going to continue the session as early as possible so that we have to end up taking 4 sessions and then back-to-back question answer session. Question answer sessions खरंच खूप चांगले रंगणार आहेत. मेटिक्युलसली क्वेश्चन आन्सर सेशनला शेवटी एक मोठा स्लॉट देण्यात आलेला आहे. आपण बाय अँड लार्ज त्या क्वेश्चन आन्सर सेशन मध्ये आपण डिटेल्स मध्ये डिस्कस करू तेव्हा सगळा पॅनल आपल्याला समोर इथे असेल and we will be able to discuss that. Questions should be directed to the chairperson and then the chairperson will guide it accordingly. Thank you so much. I would like to call the next speaker. Navratri sir, actually again the same thing, Navratri sir does not need a long introduction. He is really an iconic figure in Pune about the medical legal issues. Sir is a gold medalist at MBBS and MD, and he was 4th in his LLB, sir. Sir, it's really iconic for us, all of us. Those who have studied law and after becoming lawyers, is the trend which sir has led for all of us. Thank you, sir. Thank you for giving a medical legal contribution to the legal fraternity. Sir is an honorary pediatrician in many hospitals like Sassoon Hospital, Sayadri Hospitals and Dinanath Hospital. Sir is a past president of IMA and is known for his huge contributions in IMA for last many, like 20 years. 15-20 years of contribution to IMA. There is a long list which I really cannot read right now. Sir is a visiting faculty to ILS Law College also. And we are here athletes, many of us are athletes here. Some do cycling, some do cricket, some do badminton, and there are so many other actions which we do because health and fitness is a very important factor for doctors. आणि आपण सगळेच ह्या गोष्टीला आता इम्पॉर्टन्स देऊन कोणी ना कोणी काहीतरी नाही करत असतं. Sir is a very known marathon half and full runner. He has ran 26 marathons and he is very great at cycling. And we have a DP of sir having a racket in his hand. That's also too great for his age. Socially also, sir has been very great. He has taken a very prestigious award called Bertha Holt International Award for rehabilitating almost 10,000 family deprived children in these last many years. So this is very nice and a big round of applause. So sir, I would like to take not much of a time, take over the dais, and sir is going to enlighten us about consents and documentations. 90% of our solutions problems will have these slide. I call Chairperson Dr. Srinivas Bansal sir to kindly come on the dais. And Dr. Deepak Sarunke sir actually is not able to come, I think. I will like to call Bhalirao sir, please join for the chairperson. We felicitate Narangi sir first. I would like to call Surendra Patil sir, please do the honors. And I would like to have felicitation of our chairpersons also. Sir, kindly felicitate the Bansal sir. Sir, please come forward. Thank you, sir. Thank you. Sir, we continue the session.
Good morning, everyone, and thank you, Anjali, for a very lucid introduction. And I welcome all of you, the delegates to come on Sunday morning, as what she has introduced in the beginning. Respected Dr. Kapoor sir, my close friend, Dr. Kamath, who is my classmate also, Dr. Ghatri, Dr. Bhalirao, chairpersons, my senior colleague, Dr. Deshmukh, as an accompaniment from I will the past president, just on 1st of April. So I have one suggestion, Bhalirao sir, that in your presentation, and because of want of time, I just could not raise my hand. But then one request is that whenever the police commissioner changes, whenever the police commissioner of April is different. So whenever the police commissioner changes, we need to appease him and meet him and enlighten him about Jacob Matthew's case. So we see ultimately these sections are applied to the police officers. Once the section is applied, it is very difficult to get rid of it. And then they have to have a meeting and then they go on, the thanda karke khao. Ekda atketta karke problem. So unfortunately, probably because of ignorance of this judgment, though most of them know it, sir, we need to give this 32-page judgment to each of the new police commissioner and appraise him what are the contents of it and the last few sentences. And that is important as far as that Martin D'Souza judgment is concerned. This says that we will take suo motu action against the erring police officers if a wrong section is applied or unnecessarily the penal code is applied. So we have to highlight this. That is how we could get rid of 6 doctors who were arrested for 3 days in Hadapsar, and Rashmi Shukla was the commissioner then. And then we had to threaten that we will go against this on this particular thing. Then the charges were dropped and converted into 3048. So 3 days of arrest of not 6, 12 people, 12 doctors, 2 nurses on one case which I talked about 2 years back. So I think this is very important practical aspect that we need to appraise. See, ultimately we are knowing the sections is not adequate. It is up to the police officer, investigating officer who applies these, and we have to be very firm that this is not applicable. So in short, whatever he said in the beginning, inform your medical legal colleague first before even going to the lawyer. Before even going to the lawyer, because आपल्याला लागणारी कलम आपल्याला माहिती पाहिजे. So that only can save you. So with this, sorry, I have taken some time from your talk, but I found that this was quite important. So every police commissioner एक त्याला पुष्पगुच्छ घेऊन द्यायचा. नमस्कार करायचा. टिंब प्रथम वंदे. त्यांना पहिल्यांदा वंदन करायचं आणि त्याच्यानंतर त्यांना आपल्याला हा सेक्शन आणि जॅकब मॅथ्यू जजमेंट अँड मार्टिन डिसूजा we have to appraise them about this. Okay, so we go. So we will go to the first.
Don't want the approach to the police commissioner differs from police commissioner to commissioner.
Yes, definitely.
Last time, last commissioner in Pune, I still remember, the response to the doctor was totally different.
Yes.
Because he had a bad experience with the doctor.
Yeah.
And he started talking.
But everything against us. Yes, yes. But sir, Sama Dama Danda Veda, convince करायचे त्यांना शेवटी. So we go to the two topics I will be covering, and these are more of preventive. So I will always divide this topic of medical legal. Is not, don't get frightened. Don't get frightened. आता आपण सगळं सेक्शन सायकलिंग करतो. What we have to prepare ourselves with the proper armament. We should know the subject well, and that too only practical aspects, because we don't require LLB to know all these things. So Dr. Sonali is also here. So we divide this into, in the medical language, primary prevention, secondary prevention, tertiary prevention. Primary prevention is the ones which we are talking about how there should not be a problem. There should not be a problem. Follow your medical ethics, have most experienced technical knowledge, follow the latest techniques, everything is goody. The point is, the only point which will be of use to you in the courts and medical legal problems is your documents. Are your documents. And what Sir and Dr. Bhaler has already mentioned in section 29, this part is also defined what is meant by document. Actually the definition is quite elaborate. But then from medical point of view, this I like the definition given by McBurney way back in 1963, saying that medical record is a critical. So Sir said about document, I am talking about medical record. So medical record, why it is important? Because no record means total negligence, primary negligence. So there cannot be argument, there cannot be any defense. So no argument. Previously this has been taken view in some of the consumer cases by our doctors. Sir, we don't keep the records. It was OPD case. The courts have given, that means it is a primary negligence, so you need to be penalized. So that way the courts are saying. So medical record is a clinical. So you know how we mention about all the clinical origin, duration, progress, past history, family history, important allergies, etc., etc. I need not mention about this. They should be chronological. Number two, they should be scientific, very objective. Our notes have to be very objective. Not an essay, not a big essay, not just points also. It should be, see, the next doctor, in case you are absent, should be able to understand what is going on, what must have happened to this patient. Then administratively they are very important. They are important from educative purposes also, and it's a very legal document. It's a legal document in the point, from the same point of view, section 29, relating to the patient care, in which are recorded sufficient data written, that is entered in sequential manner. You cannot write the notes of 5th of April or 5th of May after 8th of May today. It has to be chronological. Because we are seeing such mistakes in hysterectomy notes also. You know, the case operation has been done and then consent is signed later dated. So that is not technically viable at all. So these records we should be able to justify our diagnosis and treatment. See, what is the importance of medical records? That every time we may not come to a pinpoint diagnosis, particularly in the initial stage. It is a provisional diagnosis or a primary diagnosis. Then you say SOS investigations and follow up, and ultimately, for example, particularly in case of PO, you come to a diagnosis sometimes after 3 to 6 months. But then you have to go and continue the treatment and management. So then you have to justify whatever actions you have taken, whatever actions you have not taken. So we should be able to justify the treatment and diagnosis and end result on the logical and scientific basis. See, whatever is there in the bracket is not in the original definition. That I have added for us to understand. Way back in 1965, Hathi Commission was appointed by central government, and they have given several guidelines about maintenance of medical records. So it's not a new topic at all. It's a very old topic. In short, communicate all the documented things. म्हणजे आपण जे बोलतोय consent मध्ये लिहिलंय ते explain व्हायला पाहिजे patientला. So communicate, explain whatever is there in the document, and the other way around, document whatever you have communicated. So document whatever is communicated. So what are the types of records? All of you know very well. Patient related, that is a registration, OPD paper, IPD paper, whatever is underlined is important. That is consent, and I will be covering that topic. Second is transfer and discharge notes. Certificates, it was touched upon by Dr. Bhaler. Don't give bogus certificates, don't give wrong certificates or false certificates. I forgot to underline this next part, ID of each patient, identification of each patient. That is very, very required in these particular, and every person in India now, right from newborn till the person is octogenarian, has an Aadhaar card today. So you can't say that they don't have an ID card, right? All across the width and length of the country, everybody has got an Aadhaar card. If not Aadhaar card, something else would be there. Ration card would be there. Some photo ID is very much required, at least for indoor patients. At least for indoor patients. Then CCTV footage, registers of patients, they are all parts of the document. आपण मगाशी भाजडासून सांगितलं बघितलं. Whatever is drawn, whatever is picturized, photo, even inscribed on walls is all record or all document. The third type of record is financial records like bills, receipts, PAN number, TAN number, etc. Banking, tax returns, TDS, GST, professional tax, etc. Not important today in our today's talk. Separate system of keeping the important. This is very important for hospitals. That you have all the licenses, keep them together, well preserved. Have the scanned copies on your computer, and put them on the cloud also. Another thing important, maybe some of the points may be new to you. If you are not following start today, you have so many AMCs, annual maintenance contracts. So you have to keep them updated, and when the person has come, the repair or maintenance person has come, you have to take a signature and maintain that record. On such and such date, the person has come and maintained my incubator, maintained my operation theatre, etc., etc. So those maintenance of records in both registers as well as in the soft copy has to be preserved. It's because sometimes very many things could be there that use those documents, and in course you need to prove that everything was being done, whatever care was required. I will elaborate a little about electronic and digital records. They are permissible now, but then there are certain preconditions. Police information of cases, what sir has already mentioned, in those particular conditions you have to inform and preserve those records forever. Preserve for these records forever. How long to preserve will come in the next slide. Record objectively, don't put subjective elements to this. Emotions त्याच्यामध्ये आणून घेऊ नका. I think there was a question, एकाने बायकोने नवऱ्याने बायकोला मारलं आणि त्याचे टेम्पनिक मेमरी रप्चर. You have to inform. Even if they say they don't have any control whether to inform or not. Same thing about postmortem. That it is not the choice to the patients. You have to inform once the things are required to be informed. Take Aadhaar card copy. I already mentioned. Try a call. Another thing, a new suggestion which came to my mind yesterday. लोक आपल्याला मोबाईल नंबर देतात. खूपदा तो खोटा देतात. तेव्हा त्याला लगेच तिथे रिसेप्शन काउंटरला शिकवून टाका. कि okay, there's a mobile number, you can just call them there and then and there only. See that it reaches that mobile number. This is true about employees also. And I have also, my experience is this. This is all experience is teaching me that see that आपल्या मोलकरणी चुकीचा नंबर देतात, रोज नंबर बदलतात. So once at least see to it that you call that number and it is ringing. Okay. I hope they are not in silent mode. Who writes the records? Licensed doctors, nurses and authorized persons only to write on these records. Must contain the medication, allergies, relevant past and family history. What are the skills required for documentation? Are the cognitive. That means we have to understand what the patient is saying, communicating. He has to understand and all those things. Technically, how to write the records and all that, and how to preserve them. Ethical and legal, they are important. Ethically and legally, and interpersonal relations also come into the picture. How long to preserve these records? On an average, I would say 10 years. On an average, 10 years. Why I am saying so? There is a reason for that. OPD, there is no mention in the MCI and NMC rules how long to preserve the records. There is no mention. So you may get away saying that our controlling or registering authority is not mentioning anything about it. But safer side is to preserve them for 3 years. Safer side is for 3 years. 5 years as per the ministry notification, family welfare notification. Again, after this Hathi committee, it was mentioned that keep the OPD papers for 5 years. So 1968. So that same rough guideline. But then if you have not got the records and something notice comes after 3 to 5 years or after 2 years also, you can take that defense that our registering authority does not mention about OPD records. But safer is to continue having the records. IPD, that is indoor papers for 3 years as what MCI says. better they keep them for 7 to 10 years. British courts have taken it as 6 years, so we follow the British courts, and therefore I would say keep them for 6 years, and then there could be sweet time taken by our courts to send you a notice. Even if the case has been registered some time back, the patient might have registered the case in the appropriate forum or court in time, in that it is called as limitation period. So in the limitation period for consumer is 2 years and for civil it is 3 years. So even if they have put the case in time, sometimes the court delay is there, or there could be something unusual circumstances like COVID, where the courts are not functioning, you may not receive the notice. Better preserve them for 7 to 10 years. Newborn and pediatric cases keep the records till the child attains the majority, that is at the age of 18 plus 3 years, because 3 years is the limitation period. So maintain them for, so this is a warning for all obstetricians and gynecologists and pediatricians, that they have to maintain the papers or whatever records they have for up to the age of 21 of that child. PCPMT you can get away after 2 years, only 2 years requirement is there. Medical legal 30 years. So 30 years preservation. So in short, till the time you are practicing, or I would say till the time you are living. So don't destroy those medical legal papers already registered with the police. Birth records for 30 years, as was published by Hospital Manual in 2002 by Ministry of Health. So again, birth records from 21 now has gone to 30 years. No records is primary negligence. PCPNDT Supreme Court, this is about that time it was the latest judgment that if form, आपल्यातले PCPNDT करणारे म्हणजे दोन gynecologist and radiologist. So they have to be filling the F form absolutely to the point. You cannot say that this dot was missed by me, this comma was missed by me. Now there is a Supreme Court judgment that there is no escape whatsoever. Okay. Now medical records, the characteristics of a good document are, they should be clean, hard number, complete, so the history or the story should be complete, comprehensive, that is objective. You know, it should not be too lengthy. Story लिहायची नाही आपल्याला, निबंध लिहायचा नाहीये, and they shouldn't be too sketchy also. Correct and true, chronological, date and time. Cancellation needs to be initial, right? ते काय वापरतो? Whitener वगैरे वापरू नका. Just scratch it in one line, sign it above that, correct it. Okay. Custody, whose custody it is? It is hospitals or the doctors. It should be safe custody because forgery is being tried by patients too often. So don't keep the records too loose. Always the document should be signed. एका कागदावर निदान बॉटमला एक तरी सही आली पाहिजे डॉक्टरची. आम्ही 20-20 पानाचे कागद बघतो, एकही कोणी डॉक्टरची सही नाही. कोणी लिहिलंय? त्याला आई-बाप पाहिजे ना कोणतरी. Somebody who is taking the responsibility. Only accepted short form should be used. म्हणजे the WRT with respect to accepted, fine. OC, old case, fine. But तुम्ही म्हणालात NCPD, nothing can be done. These cannot be short forms. They have to be accepted short forms in the medical field. Then consent is a very important document. I will elaborate on this.
One more point should be there in that.
Yeah.
It should be legible.
Yeah, that's what's clean and clear.
Legible also should be
Yes.
there.
This is about cyber documentation, which will take care of legibility and clarity. Those such documents are perfectly legal as per the Information Act with amendments in the Indian Evidence Act in 2000, that is sections 65A and 65B. So they are acceptable. The electronic records are acceptable. And however, there is no clear case law as far as medical documentation is concerned. अजूनपर्यंत माझ्या बघण्यात एकही case law आलेलं नाहीये. These are acceptable provided the hard disk or the CD writing is tamper-proof. So that is what is the banking system. You see, the Reserve Bank of India gives permission to the banks that there need not be a sign. आपल्याकडे आलेलं असतं बघा, सहीची जरूर नाही. Because they are digitally verified, they are tamper-proof. So that type of documentation is allowed under this Information Act as well as Indian Evidence Act, and we don't use them. So that is the one which is perfectly legal. Whatever we are using, जेव्हा केव्हा कोर्ट मॅटर येते तेव्हा त्याचं प्रिंट आउट करून सिग्नेचर द्यायला पाहिजे. So actually it is not 100% legal, but partially legal. Electronic recording should be serial and as a routine for all the patients. But एका patient electronic, एका patient electronic असं नाही चालत. Everybody has to be electronic only. EHR is a separate topic by itself. That is electronic health record for the patient. And for the time being, we as medical legal experts would advise to have important documents in physical format. म्हणजे कुठले इम्पॉर्टंट नाही, पोलिसला इन्फॉर्म केलेले, जिथे काही मिसॅक झालेले असे जे कागद आहेत, जिथे एक्सपेक्टेड मेडिकल लिगल प्रॉब्लेम्स आहेत, वेळीच प्रिंट आउट करून सही करून ठेवा, वेळीच. सो दॅट इज द वन विच दिस इज माय पर्सनल ओपिनियन. कपूर सर कॅन डिफर अँड ही कॅन करेक्ट मी इफ आय एम रॉंग. बट देन ॲज ऑफ दिस मुवमेंट our courts believe more in the written physical documents rather than unless we have the tamper-proof digital records. Whose property are the records? The creator is the property holder. आपणच create करतो records. आपलंच ही property आहे. Hospital has the right over the papers even if the patient has paid. Patient-related documents, reports, etc. But should provide a copy to the patient or his. This is important. Or his first-degree relative. If the patient is not alive or is unconscious, or to the court or to the police. So we can provide to these three categories only. Investigating police officer, if he has brought the notice in writing that you provide us the original documents, they require original documents. Number 2, court, and number 3 is the first degree relative. त्यांना आपण xerox copy द्यायची, original आपल्याकडे on a written demand. Otherwise, it is a confidential communication and we should not divulge these papers easily to anybody. Insurance companies demand a full set of papers. It is understood that the patient has given consent for that and they are asking for the reimbursement as he is claiming the reimbursement. While handing over any document, number them serially. 1 ते 40 पान आहे. 1, 2, 3, 4, 5, 6. Label the numbers. Number 2, take a xerox copy after labeling numbers. आणि जेव्हा तुम्ही देता त्या पानावरती सही करून ते घेतात तसंच पोलिसची पण सही घ्या किंवा रिलेटिव्हची पण सही घ्या. नाउ अबाउट रिलेटिव्स आय वुड जस्ट गिव्ह अ हिंट that recently 2 incidences have occurred that भावाभावांच्या भावाबहिणींच्या मारामाऱ्या चालू, internal fight for the succession, and everybody is coming one after the other after 2 months, after 1 month, 3 months, आम्हाला एक कॉपी द्या, आम्हाला एक कॉपी द्या. So here we should take in writing that one copy is given and that I will take the responsibility of giving the xerox copies of these to other relatives. नाहीतर पुन्हा एक हेडेक होऊन बसतो प्रत्येक हॉस्पिटलला की everybody requires one copy. This is an important document, discharge card. A very important, whatever is going in the patient's hand is important. Whatever we are giving in the patient's hand is very important. That is discharge card. Any certificate, any instruction sheet, any prescription, because it is in their hand. A very important document goes into the patient's hand. Never give this responsibility entirely to the nurses or the junior residents. You have to see it before it is handed over to the patient. खूपदा त्याच्यामध्ये फॉलोअप लिहिलेला नसतो. Follow-up instructions are poor. When to come is not mentioned. How to take the medicine is not written, and so on and so forth. Whatever investigation. So you have to mention all these in the discharge paper. Then you sign it and hand it over. So it should not be just left to the juniors because they are not aware of so many things. Always give contact details for an emergency as well as for follow-up details. Just for a little mistake, courts have awarded severe damages to the extent of 20 lakhs by Delhi State Commission. चुकीचं discharge card भरलं म्हणून 20 लाखाचं compensation द्यायला लागलेलं आहे. Always keep a copy, and so many other judgments are there. Keep a copy of the discharge card with the hospital record. हे खूप लोक करत नाही. So have that copy attached to the total set of case papers and write the advised investigations and follow up on discharge card. If not followed, it will be contributory negligence. थोडक्यात म्हणजे आपण advice दिला, common such and such date, have the investigations done, follow these medicines, and the patient does not do these. It is a contributory negligence by the patient, and therefore your severity of negligence goes down, if at all it is there. Medical records, prescription as far as possible need शक्यतो capital letters मध्ये द्या किंवा टाइप द्या, computerized द्या. Strength of medicine must be written, correct dose, etc. I think there is a format given by MCI and NMC, so you can follow them. खाली त्याच्या registration number टाकणं आवश्यक आहे. Registration number beneath that is a must, and always give a follow-up date. कुठलीही ट्रीटमेंट पुरी झाली असं म्हणूच नका. You always give a next follow-up date. आम्हाला माहिती आहे काही करायला लागणार नाही, but put a next date. That is a defensible. That is how you will protect yourself. So if the patient does not come, you can always say he did not come. I had asked to come. Okay? तोंडी सांगा नाही आलं तरी चालेल. मेन्शन करताना पुढे follow-up date. There are very many reports about sir, Valero sir, this is your point, that they should be legible. So this is a study was done in Calcutta in the year 2000, that what is the prescription legibility in Calcutta Medical College, and that showed that more than 6,000 new prescriptions were seen, checked, and in 1997-98 the paper was published in 2000, and it shows that only 44.67% of the patients could tell the correct dosage, whatever it was written, whether they have understood or not. So more than 60%, more than 50% don't understand what has been written. Similar studies about legibility were done in England, and over there it was 65%. They were illegible. Both can be avoided by electronic prescription. And the next point is the clinical point, that prescription audit is also required. So whether the medicines being given are correct, we should introspect ourselves. There are going to see particularly I feel this so with the ICUs. Whether what is happening in ICUs, anybody is opening up ICUs, whether we are introspecting the treatment going on was methodical, the death is acceptable to the extent of 40%. But then whether the things were done, whether there is active harm done by the hospital or the doctors, so that the management needs a change, has to be really introspected every 3 months. About a transfer note, carbon copy should be kept. Carbon copy or a duplicate should be kept, and take a signature on that they have received the transfer note. They have received the transfer note. Otherwise, one judgment has come from again Delhi State Commission, which to me is rather unjustified. That they had given the summary of the notes while transferring to the next hospital, but because the full set of papers was not given, again the consequences were damages awarded for something around 19 lakhs. So do we give a full set of papers to the next hospital? So far as I have practiced, it's a summary, and of course salient features are mentioned, and in case required, we can mention that whatever further information is required can be provided willingly on request. So that can be done. We don't hand over the full set of papers to the next hospital, but then for that there is a judgment for this. So I would say just follow the same. It is ultimately how your lawyer has fought. So law depends on what your lawyer has fought. Put a date at the time of transfer, always accompany. Somebody should accompany in that ambulance while transferring. Write the treatment summary and your assessment of patient's condition. Some trained doctor has to accompany. A format is prepared by us. We have prepared a format in case you require, we'll send you one. And whether to give full set of papers, I have mentioned about this judgment in 2018. So this is the end of my first part of the medical records. A lot can be talked about it. Write the advised investigations on prescription also. Always give next appointment on paper. Keep the addresses of all your staff for 10 years, because your staff goes on changing from one hospital to the other, from one particular ladies. They get married and they can go to Delhi or anywhere else also. Right now, yesterday evening, there is a case where from DY Patil, that lady houseman on which there is a criminal charge, she had left about 7 years back, and they have to trace out. But then we have the other card and all these other details, so the summons can be sent over there. Don't overthink of the patient's pocket. So whatever is required has to be done. Seek the help before submitting. Seek the help means seek the help of a medical legal expert before going anywhere else. Now, the second part is consent. It's a huge topic, and most of the cases are won or lost on this point. But then we have to restrict ourselves. I will give only salient, important features of practical importance in India, and the law of consent is practically the same all across the world. So it is a comparative law study also. So consent is covered by 2 acts. One is by, sir has mentioned already, about the Consent Act in the Indian Penal Code, which is the saving clauses for doctors. So for example, if I touch him, that is also an offence. That is called as offence of touch without his permission, though there is no intention. But to touch somebody else physically is also an offence of battery. But then we are examining the patient, touching him, we are purposing, auscultating. Percussion is the lost art now. But then we are touching, we are taking the incisions and all that. Then there is a saving clause. What are these? These are sections 86 to 92. That is your consent part. So we are allowed to do that. So consent is actually covered very nicely by Indian Penal Code, one aspect. It is also, consent is required under, it comes under Companies Act, Contract Act. So Indian Contract Act of 1872, and that is where the consent, both parties having the same thinking, doing the same thing in the same fashion for a legible cause, for a legal cause. So there cannot be meeting of minds for illegal cause. एखाद्याला murder करायचं आहे, 4 लोक एकत्र, that is conspiracy. But when patient and myself are agreeing to get appendix done or hysterectomy done, meeting of the minds after getting explanation and then need of that particular surgery or particular procedure, both the parties are agreeing, that is consent. That is consent. Okay? So that part is covered by Indian Contracts Act. So we have legal foundation for that. Now what is Indian Contracts Act say? That it defines consent in the section 13 when 2 or more persons agree upon doing something in the same sense for lawful purposes. For lawful purposes. They are in contract. They are in contract with each other. It is a union of wills and accord in minds of parties. So that is a validity of the contract. थोडक्यात म्हणजे आपण कॉन्ट्रॅक्ट ओपीडीला पेशंट बघतो. We don't take in writing, but it is an implied consent. Implied means understood by behavior. So, but then there is, the patient wants to get examined from me. I want to examine him, come to a diagnosis and treat him. And then against that they are giving me money. So that is the completion of the contract. It need not be written every time. But for anything which pierces the skin of a person, anything which that is now defined, whatever is piercing, going through the skin of the person, or you are doing endoscopy, you require a written consent. So that is the law of the land. That is in India, not so much in England. So everything is to be required in most of the hospital things are you require a written consent. Invasive procedure is now defined as skin barrier is transgressed or endoscopy for biopsy, lavage, etc. So in one endoscopy, you are not crossing the barrier of skin, but even then it is an invasive procedure as per this definition. So consent should be person specific. हे सगळे section 1 to 5 आहेत ना, हे सगळे contract act मधले आहेत, म्हणजे Indian Contract Act मधले आहेत. Yeah, you require injection. You take one consent once, and that can be a continuing consent. You have to have a consent at OPD level once. त्याच्या पेपरला लावून ठेवा. Yes, very much. Ideally, yes, and everything needs to be ideal now. So consent should be person specific, section 1 to 5. Hence, ID proof is very important, and procedure specific, section 13. When about a particular thing, so it should be the procedure specific. Disclosure of full information is required as per section 17. Don't suppress any information. It applies to non-disclosure by patient also. म्हणजे माहिती कोणी द्यायची? Doctor is required to give information about the disease and the treatment and management to the patient, because you know more about these aspects than the patient. So that is called as fiduciary relation. But it's more complicated. But we as professionals required to give information to the best possible to the other side. Whereas patient also should not suppress any information. म्हणजे आपल्याला कन्सेंट मध्ये ऍड करायला पाहिजे की मला होत असलेल्या सर्व माहिती आणि आजाराची माहिती मी डॉक्टरला दिली आहे. So this is one new thing that patient has said that I have disclosed everything. Okay. Section 7 to 9, it should be preferably a written consent. Now it is a must. Now those Supreme Court decisions say there has to be written consent. So that's another thing. Signed by a competent person. Who is a competent person? Who is more than 18 years of age and of sound mind. These are the competent people. Competence means legally competent. Age more than 18. आता age कसं बघणार? आधार कार्ड. PCP entry, very important. POXO Act, MTP. You have to have आधार कार्ड. आता मला म्हणून चालणार नाही की मी बघितलंच नाही, ते काय माझं काम नाही. सेकंड इज साऊंड माइंड. साऊंड माइंड मीन्स जो थिंकिंग करू शकतो, हू हॅज सम कॉग्निशन. आता आपण कुठे आलोय, कुठल्या हॉलमध्ये आलोय, सकाळी का रात्री आहे, काय चाललंय आता. सो द पर्सन इज oriented to the situation. Consent must be free consent. Means it has come voluntarily. See the meaning of voluntary. Sir was telling in the slides, voluntarily in the Indian Penal Code. The meaning of voluntarily in Indian Penal Code means knowingly, purposefully. Whereas what I am talking about, free mind is voluntary, means he has come to you in the ordinary sense of meaning of voluntary. It's different. Without undue influence, कोणी त्याच्यावर प्रेशर करता कामा नये. Or persuasion. त्यांनी तुम्ही केलंच पाहिजे, नाही केलं तर असं होईल, काहीतरी भीती दाखवायची, ते पण बरोबर नाही. Misrepresentation or fraud or mistake of fact or law. So informed as to the nature, manner of treatment, Indian Penal Code 87 to 92, sir, as I rightly mentioned, these are exception clauses. Consent should not be given by a person under threat, misconception. That's the negative. आपण म्हणतो do's and don'ts. आता do's बघितल्या. It should be free, it should be voluntary, it should be coming after understanding everything, not through undue influence. आता इथे negative. It should not be under threat, misconception, pressurization, misrepresentation, unsound mind at minor age. When to take the consent? This is a very tricky topic. I will cover in the subsequent slide. Now about Indian Penal Code. This is important. खूप लोकांना माहित नाही म्हणून मी स्ट्रेस करते. Who can give the consent? I had mentioned the person who has attained majority. But then what about children? Children undergo several procedures, isn't it? Any child beyond the age of 12, you take additional consent of the child as per Indian Penal Code. Indian Penal Code says that below 7 years, there is no competency of the child. Below 7 years, no need of the consent. Between 7 to 12 years, it is up to the judiciary to say whether the child is understanding the consequences of that particular act or omission. So you may not take the consent of the child. They are not very correct. But beyond 12, they have said child does understand the importance of whatever is going to be done to him or whatever is he going to do. ते पण गुन्हेगार पण होतात ना, juvenile act असतात. So beyond 12, I would say that primary consent should be of the parents. Primary consent सही कोणी करायचे? वडिलांनी करायचे, आईने करायचे. In case of institutional children, it should be of the guardian. But then child himself or herself, 7 च्या खाली नाही. 7 to 12 you may escape. Above 12, I would personally say take a consenting party, additional consent to the child. एक सही घेऊन टाका. It is safer. त्याला पण मजा वाटते. आपली पण सही घेतली. Maturity will be assessed between 7 to 12 by the courts, and Indian courts have done the same. Consent and denial are two sides of the same coin. आपल्याला नेहमीचा अनुभव consent माहिती, तो willingly आलाय, surgery करून घ्या. At the same time, patient is there for some reason, and you tell him now surgery is required, and they say no. Again the same way, that patient's autonomy comes into picture. He or she has the full right to take a decision about the body of that person, whether to go ahead. Even if I'm going to die, I will not take it. I will not do the surgery. There is a cult in Christianity called as Jehovah's Witness, where they do not take any blood or blood products, called as Jehovah's Witness. And they give in writing, even if I die, I will not take blood or blood products. Organ transplant is a very important thing. So over there, they have the full right to deny it. So same thing, denial of the consent should be recorded and then preferably witnessed also. 2 witnesses, the competent witnesses should be there. Competent means of sound mind beyond the age of 18. Please record in writing and witnesses, and any refusal or denial is more important than even consent. Some important cases are, I just give one case from UK, that a child can consent if of sufficient maturity. This is a case of Quincy. Quincy has no peritonsillar abscess. She was suffering a lot. Age 9 years, she had given her own consent, and surgery, the dilemma was there for the surgeons, whether they can go ahead with the only child's consent. It's a life-threatening situation. And the parents were categorical, saying that no, we will not give consent. Then they went ahead with the child's consent, and it was upheld by the High Court in UK. Another is Arunachal Vadiwal versus Gopi Krishnan, where thyroid adenoma was operated on oral consent in 1992. Please don't do this now. Please don't do this. After that, Supreme Court decisions have categorically mentioned, whenever there is an invasive procedure, you have to have written consent. त्यावेळचे लोक सुटले, आपले कित्येक थोर लोक सुटलेले आहेत, परंतु आपण आता सुटू शकत नाही. दिवस बदललेत, way to change. Another case of T.T. Thomas. This is a famous case from Kerala. She was a nurse herself, and had bad appendix, and the consent was not given by her. Relatives were yet to come, and because denial was not recorded, the court said that there is no denial given. You are saying there is not enough evidence, and the State Commission and even the National Commission gave a confirmation of the damages to the extent of 5 lakhs rupees. So denial needs to be recorded. Consent should be by a major person of some moment. I already mentioned must be free, valid. म्हणजे त्या sections मध्ये लिहिल्याप्रमाणे असायला पाहिजे. In the language of the patient, mention the name of the procedure and anesthesia. Alternative modalities should be mentioned over there. 2 independent witnesses preferred, particularly in expected medical legal cases. Simple to understand, language should be simple to understand and specific for that procedure. Mention usual, general and procedure specific complications. I think this was a question. What is meant by usual? What is meant by common? What is meant by unusual complications and unforeseen complications is now luckily defined in another case called as Samira Kohli versus Prabha Panchanda in the year I think 2008 or 9. So that case has gone a little against medical teaching, but this thing is mentioned that if the occurrence of that particular complication in that procedure is less than 10%, need not be mentioned. Less than 10%. In my opinion, 10% is a huge number. So preferably come down to 5. And in foreign countries, it is less than 2%. So if the complication rate is more than 2%, you have to mention. If it is too remote, what is meant by remote according to that judgment which is being followed? More than 10%. Sorry, less than 10%. So need not be mentioned. But then there are other judgments from, we have to go for comparative legal study all across the world also. So there are Montgomery's decision, then there is Whittaker's decision in which it has been mentioned 5%. So better err on the safer side. Whatever complication is likely mentioned more than 5% occurrence needs to be mentioned even in India. So we should be one step ahead of law in this country. 2 independent witnesses, so easy to understand. General complications, bleeding, nerve damage, infections, you mention them. Pain, that will be there everywhere for every surgery. So mention the common procedure specific if it is more than 5%, and the remote one you don't know also, it has not been reported also, you need not mention. Name of the principal doctor should be there, anesthetists, assistants. In case of an emergency, surgeon or HOD or dean himself can give the consent on behalf of the relative or the friend, and that is allowed. Consent is required. Unknown patient. Accident case एकदम एकालाच आणलाय फक्त बाकी कोणी नाही. Accident मध्ये कसं असतं? Patient is brought unconscious, nearly dying, and those who bring they all run away. Whose consent is then to be taken? It is the operating surgeon can give the consent and go ahead. So life is first. हे सगळं consent वगैरे बाद आहेत ना, हे सगळ्या old cases, planned cases. However, please remember the red ink. Consent, beautiful consent, is not a license to commit negligence. Okay? So you cannot say that I have taken wonderful consent and everything was explained and everything is there, signatures is there, all the components of a valid consent are there, and I commit something terribly wrong. It is not equivalent. Negligence is negligence, consent is consent. But not taking a consent is a primary negligence. That's okay. But absence of consent itself is a primary negligence. Negligence per se and goes against you. If proper, it may save you. It may current legal burglary jugglery. So consent is the one which top lawyers say that we can floor you even if the best consent. But then we are also there. So don't get carried away by whatever they say. The good consent is very important. Not taking consent is negligence. Having a good consent is not a license to commit negligence. It should be procedure specific, and that is the landmark judgment which I already quoted is at Samira Kohli versus Prabha Panchanda case of 2004 to 2008. The pronouncement came in 2008, and over there they have mentioned आपल्याला काय शिकवलेलं आहे? In case you open the abdomen or anything and your diagnosis, see, the abdominal pain even today is a mystery. Even with, see, today you have got MRI and PET scans and everything is there. They are beautiful. But even then, diagnosis can be giving you and something else can be found on table. This is particularly true in congenital heart disease also. In this case, we haven't taught that finish the job. Somebody should go outside and explain to the relatives that this is what is consented for. But then we feel that this should be done. And they give the consent and you do the procedure. And after the patient comes out of anesthesia after 2-3 days, when the patient said, you can tell that this was required and it has been done. That is no more allowed after this Samira police case. It has to be very specific. It is very specific. You bring out the patient of that anesthesia. Let the patient settle. Do another procedure after 2 to 4, 5 days by taking another full informed consent. However, आपण सगळं ऐकतो ना, अर्धवट ऐकतो, पुढचं ऐकणं महत्त्वाचं आहे. This does not hold for emergency situation. For example, exactly 1 month after this Samira Kohli case, there was a case of same endometriosis. This is endometriosis case at nearby Tarachand Hospital, not in Tarachand, nearby Tarachand Hospital, where there was a cut on the uterine artery, and they had to resort to total hysterectomy. Young lady, unmarried, marriage was planned 20 days after this particular surgery, 2 months after, Muslim community. So you know the mob. And they had to remove everything. In this Samira Kohli itself, it has been mentioned, unless it is life-threatening, you have to bring out of anesthesia, etc., is okay story till the time it is a planned thing. If there is an on-table emergency, you go ahead and complete the procedure. Okay? So remember the exception also. Then what is the take-home message? In case some other alternative procedure is required, there are 2 messages from me. Sir, you can elaborate on this later on. One is that you have to show that there was an emergency. Or the alternative is that you name a proxy who will give consent and will be taken as valid. आपण जो consent form आपल्याकडे आहे त्याच्यातच लिहायला पाहिजे, in case such and such situation arises and additional procedure or alternate procedure is required, I request the doctor to complete the procedure after taking valid consent from my proxy named so and so. And then that is okay. Then so that new change needs to be done in the consent. So printed consent, another thing, आपण सगळे printed consent. We are following printed consents. How can I write all these things every time? So printed consents or typed consents are quite okay. However, there is a very clear, very unusual decision from National Commission, I think 2 years back. Yeah. So that decision is challenged. Said it cannot be a printed consent. But then practically it is not possible to take all these detailed consent. So we go on using the printed consent follow. That is the practice of local or say all across India. So we follow whatever the things are there, and you will be saved in my opinion. But then Supreme Court decision is yet awaited. So right now National Commission decision is there that it cannot be a printed consent. I think I will skip it, taking just 2 minutes. How to take the consent, when to take the consent. This is a recent formula we have introduced in the last 3 years in Pune, and it is getting followed in Pune hospitals, that we make 3 copies of the consent. 3 copies of the consent are given and handed over to the patient at the time of fixing the surgery, fixing the procedure. So that patient has ample time to go home, think about it. Then they cannot say that we did not understand this and that. They can consult their doctor also and take a signature and ask them to bring 2 copies while coming for surgery and getting admitted. So 1 copy is remaining with the patient, and they bring 2. 1 goes to our hospital record and 1 goes to the OT record if it is separate, or to anesthetist record. So 3 consents, or you can send email of that consent form and they can make 3 copies and come to you and then sign. The consent should be preferably within 48 hours of the procedure and also the procedure. So this is an ideal perfect scenario that you are giving them ample time. They have thought over the procedure and you are taking the consent again on the day of surgery also. So this is a good alternative to that. So remote is less than 2% as one decision from USA that from UK not reached, but then 5% is okay for us. Samira Kohli I already mentioned, but now another decision has come again from Supreme Court, in 2014, a 1996 case decided in 2014. It's a gallbladder case. You know very well, gallbladders are getting removed and by laparoscopy. And sometimes you require an open surgery. The consent was for laparoscopy. So it was procedure specific. And over there, there was an empyema of the gallbladder, so sort of an emergency. The surgeon went out, took the signature of the relatives, and procedure was done. The case was contested, and it was the decision has come in favor of the doctors that this particular thing which is done by the surgeons is correct, and this is still allowed in spite of the Samira Kohli's decision. So this I already mentioned over there. I would say that just add one sentence that I have been well explained in simple and understanding language, and also I am satisfied with all the answers to my queries. And further, I have been conveyed that I can have further information from the websites, not net sites, it should be websites provided to me by the doctor, and I will think about them again, and if there are any more queries, I will ask the doctor again, and he is agreed to give the information. So that sentence is there in the consent now. So add this proxy consent and everything is done. MTP tubectomy specific consents are there, and do not forget to get the consent of the partial woman. हे काय सांगायचं मला याच्यामध्ये, this is the last one. So आपल्याकडे काय होतं, डिलिव्हरीला पेशंट येतो and expected is normal course, normal delivery, vaginal delivery, and at the last minute fetal distress is there, and you feel that surgery, cesarean has to be done, last minute emergencies, cord blow exposure, so many things are there, and the relatives are not there, husband has gone to bring tea and all that. We forget to take the consent of the mother who is going to deliver or who is going to be operated. Her signature is many times not taken, and just we go on waiting for the husband or mother-in-law and father-in-law, etc. So that is not correct. You have to take the signature of that parturient mother herself. In addition, if somebody is there, take an additional consent. So with this, I come to the conclusion of my talk. I will skip this living will and all that. Thank you very much for patient listening. The topic is really vast, and it is up to you to do it in a proper sense, in a proper legal way, and don't go for the shortcuts, and don't hesitate to take a denial also. This is my particular.
Now, one correction. MTP records, as per MTP Act, have to keep minimum for 5 years. It's said in the MTP Act, not 2 years. So they should not go with the wrong idea.
Okay.
5 years minimum.
Okay. Thank you for
Other
the
record is 3 years. MTP 5 years minimum.
Yes.
Please remember that.
MTP record cannot be given in the patient.
Cannot be given. No, these are special cases. So special acts will supersede the provisions in the IPC. So whatever special act is there, PCP and MTP. Thank you, sir, for correction. Thank you. But the cases come after 12 years, sir. In MTP, after matrimonial discordance, the cases are coming after 12 years.
Yeah.
But then you have a defense.
After 5 years, you can say that I do that.
Thank you, sir.
It's a common customary, at least when we say taking consent, many things happen because of miscommunication or not communicating properly. We have a customary, posting any patient for surgery, we get all the necessary investigations done, and then we refer this patient to physician and or anesthetist, and we say referring for fitness. That's a wrong customary to say. You have to mention referred for pre-operative assessment. When the surgery is necessary, you cannot make him unfit, but in assessment, you say with due risk. Now it has become a fashion on behalf of either anesthetist or a physician to write patient fit for surgery with due risk. And that is the place where you land in trouble. Neither the physician nor the anesthetist explain completely to the patient what are the due risks. It has to be mentioned on his consultation paper, or in case of indoor patient should be mentioned on the indoor case paper record. Because when the patient comes to the surgeon with a note fit for surgery with due risk, साहब देखो ना हमको फिटनेस तो दिया है. With due risk, patient has ischemic heart disease, patient has diabetes, patient has hypertension, underwent a major surgery prior also. साहब इसने तो फिटनेस दिया है. अरे बाबा लेकिन इसको ये फलाना फलाना सब कंडीशंस है, बाकी तो सब नॉर्मल है नहीं. This is how the patient defends for himself, but it is duty of the physician as well as the anesthetist to mention clearly what are the due risks. Thank you.
One question. And I want, yes, sir, for the denial consent, whether the audio record will be sufficient, because at times the patient says we are not giving the consent and we are not giving the denial consent. So that can we have audio recording of this conversation?
Ideal is to have.
The ideal thing would be to take a signature, and audio will be supporting, because it is ultimately if the case goes to the court, it will be up to the court to find out the authenticity of the record. So you will have to prove that it is an authentic record.
But the audio visual
is the best.
Recording
is the best.
Does it need consent?
Yes. Written consent again is it? See, written is written. It has to be done.
Yes.
But audio visual is additional good support.
Yes.
Thank you, sir.
I think he deserves a big applause. Thank you very much, sir. Thank you.
I'll hand over the mic for a few minutes to Dr. Mahesh Kudre, sir. He will be felicitating Krishna Diagnostic officials and will be doing the officials.
Thank you, madam. Morning. प्रायव्हेट हॉस्पिटल ओनर्स असोसिएशनच्या वतीने मागील 15 दिवसापासून अंजली मॅडमने बरेच अथक मेहनत करून आज हा दिवस आपल्या समोर घेऊन आलेले आहेत. पडद्यामागे बरीच मेहनत आपल्याला करावी लागते. त्याच्यामध्ये अंजली मॅडमनी जे कष्ट घेतलेले आहेत ते खरंच वाखाणण्याजोगे आहे. सर्वप्रथम आपण त्यांच्यासाठी जोरदार टाळ्या वाजवूया. आणि हो, आता कोणताही प्रोग्राम आयोजित करायचं म्हटलं तर स्पॉन्सरशिप ही लागतेच. तर आज हा प्रोग्राम आपण ज्या प्रिमाइसेस मध्ये घेत आहोत, कृष्णा डायग्नोस्टिक्स, सर्वप्रथम I am really feeling so very grateful to you for your actually have been too generous to thus give us this sponsorship, with the very help of which we were actually able to organize our event properly. हा इव्हेंट प्रॉपरली ऑर्गनाइज करण्यासाठी तुम्ही आम्हाला मदत केली. आम्ही आमच्या असोसिएशनच्या वतीने नक्कीच तुमचं स्वागत करू इच्छित आहोत. कृष्णा डायग्नोस्टिकचे व्हीपी मिस्टर VM शर्मा सर इथे उपस्थित आहेत. मी त्यांना इन्व्हाइट करतो, त्यांनी समोर यायचं आहे. संदीप चांदोर सर, अनिल आटकर सर, त्यांना मी आमंत्रित करतो. तसेच कृष्णा डायग्नोस्टिक आदर्श कर्नाल सर इथे उपस्थित आहेत, त्यांनाही मी पुढे आमंत्रित करतो. तसेच सर्वच ट्रस्टियांना मी विनंती करतो त्यांनी समोर यायचं आहे. अजून 2 सेशन आपले उर्वरित आहेत. त्यामध्ये डॉक्टर ललित कपूर सर आणि ओपन सेशन हे अजून आपले बाकी आहेत. तत्पूर्वी कृष्णा डायग्नोस्टिकच्या ऑफिशियल्सना विनंती करतो, त्यांनी आपल्या 5 मिनिट्स मागितलेले आहेत, तर त्यांचे जे काही व्ह्यूज आहेत ते इथे त्यांनी सांगावेत.
Good morning, everybody. My name is D.M. Sharma, and I represent Krishna Diagnostics as Vice President Operations Strategy. As you all are aware of, that Krishna Diagnostics is one of the largest, PPP company, which is public-private partnership company in India. Today, we are present in more than 16 states, where the government, calls us and give us opportunity to serve the nation. Our strategy and our process of organization is that let's do good for the society. We are the pioneer in bringing down the costings of radiology investigations across India, and the people are following us. So this is what actually Krishna Diagnostics is. We have all the facilities. In Pune, we have multiple number of facilities available, which includes your MRI, CT scan, digital X-ray, ultrasound, then your mammography, teleradiology, and pathology. I just wanted to bring very important point to be discussed out is teleradiology. We are the largest player in India today to do teleradiology solutions for government of India, and we do it for across the nation. We have 250 plus radiologists, with us, who's been actually, working for us day night, 24/7. So that's an advantage, and even governments, like Telangana government, Meghalaya, and multiple other governments have been actually inviting us for giving the solutions, because as you all know that radiologist community is very, scared, and that's the reason, the governments also require support for it. Today actually I've been, talking about something which is a very important, thing for a hospital side, which is hospital lab management. And in hospital lab management, it's a very highly functional area where, investment in terms of technology, manpower and equipments and all becomes very tough. So whenever we try to, run a laboratory, it's very important to have that accreditation of laboratory and processes need to be done. Then the accreditation conformity is also another aspect where we talk about that NABL, NABH, all those processes are very important for running pathology, for the quality reporting. So we've been just talking about this HLM, what are the any kinds of importance of HLM and how we will be able to help put. So why it is HLM? HLM is hospital lab management. Its first is the cost alignment process, where a reference laboratory partnership can reduce your laboratory testing cost through a combination of economic of scale and utilizing our lowest test cost. So that is the one thing where you will be able to get benefit out of it. The equipment and the supply cost represent the second highest category, which is behind labor for every hospital lab, which is also saving opportunity in this area. Third is that typically laboratory reagent costs are rising by rate of 2% to 5% per year. as you know that, the whole things have been changing, dynamics post, Corona also. The KDL partnership can reduce the rate of this increase of the test costing. KDL is my Krishna Diagnostics Laboratories Limited. Additionally, our HLM will also enhance the profits by sharing outside specimen testing revenue and profits. So we can bring more number of specimens to your lab and can test. So you will become my hub lab for processing investigations, and which will be reducing my turnaround time to the customer and to outside as well as inside patients together. Our partnership eliminates a further financial investment in the laboratory operations when volume increases at hospital level. Strategic focus. This is very, very important because there is a significant opportunity in inpatient, the laboratory testing from physician to their hospital laboratory. However, inpatient lab services are typically not best at providing efficient testing services to physicians outside the wall of the hospital. This is basically a basic, thought process. Many doctors are recognizing that reference lab testing is not a core competency of a hospital lab. So the time, cost and effort provides the highest level of integrated lab services to physician is impacting the focus on their strategic important activities. Hence, the hospital seek out for a partner with sophisticated system and resources to address their reference lab needs. So this is what actually we have been putting up. Then again, leveraging the lab data to reduce the downstream healthcare cost, which includes that laboratory testing typically runs 3 to 5% of a hospital overall budget. However, lab testing impacts up 70% of clinical diagnosis and decisions. There are numerous studies that have published that indicates providing the right testing or combination of tests at right time not only improves the patient outcomes, they eliminate unnecessary expensive procedures and reduce a hospital length of stay also. Hence, providing the right test at right time is not as simple as it sounds. This often involves a reflex testing, appropriate testing algorithms, and pop-up notification upon testing order entry. The KDL has invested in softwares to integrate these programs into LIS to ensure good results. What are the potential benefit of HLM? It improves the ability to cost-effective perform more testing in the hospital laboratory, provides a lower inpatient laboratory cost structure as per mutual consent, enhances the hospital profit by sharing outside lab testing profits, provides a reference laboratory services that is competitive from the competitive labs also, improves the integration of inpatient and outsourced laboratory testing services, provides access to KDL countrywide supply and lab equipment cost structure. Pitfalls of the HLM, hospital lab management, because we have to look at positive and negative both. But the biggest pitfall of the hospital is that they have to work with another organization which is typically outlined above. So usually this is what the first pitfall. The second pitfall is that hospital always typically are concerned that the loss of control over their lab operations. For that, however, KDL's lab partnership builds a control provision in the document which assures that your adequate safeguard for the hospital of lab operation processes. So we always keep that safeguard also. What we are offering. So first of all, laboratory operation processes as per ISO 15189 or NABL guidelines, good lab practices and standard operating processes, SOPs, expert and experienced pathology school of KDL, the support from sales and marketing team for increasing business inside and outside the business. Then regular internal quality checks for EQUAS as per NABL protocol, launch of various packages based on the opinion of hospital doctors and market feedbacks, access the extensive clinical test menu of KDL including diagnostic and radiology facility, prerequisite expertise to upgrade and operate existing lab to maximize the productivity and efficiency for a world-class quality testing in-house facilities and to ensure the better ROI in the hospital. But it is also important that logistic connectivity is very, very vital here. So efficient logistic support for the specimen transportation has also been added support from our side. The quality of services with efficient turnaround time and the IT support in terms of LIS, HIMS, whatever the being processes, we also give a support from our side. why KDL is different from others? That's more important, because you'll say that why there is no other people. So what we offer is the lowest investigation rates as compared to any other competition in India today. So we have come in the private business also, and the pricing which we're going to offer will be lowest across nation, as we have already done it for radiology also. Everybody knows about it, I think, probably. Another thing is KDL team operates the hospital lab in a highly organized process with utmost quality and better turnaround time through experienced technical staff and pathologists. The quality is approved by daily QC, EQUAS, FDA approved machines. The KDL team makes continuous hard effort to improve in-house lab tests based on the workload. We also give a marketing support which works continuously toward improving the footfall of the patients in your hospital. The KDL quality team brings international quality management system which achieves throughout the strict monitoring of processes and SOPs. KDL also provides a training for the technical staff based on the recent lab practices, and pathologists need to mandatory attend the CMEs on improving lab quality of their labs. Now, what happens to the existing staff and my equipments? I think it has, just went in. So KDL does this technical evaluation of existing staff, retain them on the basis based on pathologists and hospital feedback. An instrument can be used if they are approved under standard machine list of us. The responsibility of hospital and a revenue sharing. The hospital need to provide a basic lab along with AC, UPS supply and internet connectivity. The complete details of their in-house doctors and consultants along with their details. Complete required documents to H&M team for evaluation of project and its finalization. KDL has an attractive revenue sharing model based on financial price approved by the hospital and KDL team together. The KDL will also handle all expenses of laboratory including consumables, reagents and manpower on an agreed revenue share terms. So this is what actually we have been working on into it. This is some of the centers which are having all these facilities. And this is our actually presence. I'll just put up a small video which will be able to we just recently shooted out. This is our lab. Now we are opening the collection center models, B2C and other processes also. That's all from my side. We'd like to request and if somebody from our this group would like to work with us in association with this process, we have been